Okay, so we'll just get started. So yeah, just as May said, we'll be going through PHARM, Pharmacokinetics, Bacterial Pathogenesis, and CLIN skills, elbow, wrist, and hand examination. It's all fairly simple this week, so it should be a fairly short and quick session. So I'll start by taking you guys through pharmacokinetics. So first off, just with pharmacokinetics, the first thing is to understand that pharmacokinetics is essentially the effect of the body on the drug. So that means absorption, distribution, metabolism, and excretion of the drug. And there are a few important applications that you should know about. This includes equations and also just general understanding. So here you have the distribution of drugs, which is called the volume of distribution. You have metabolism, which has the rate of clearance, and the rate of clearance of a drug, and then also the rate of elimination, so CLRE. And then you also have elimination kinetics, which tells you about how different drugs are eliminated from the body. So first, to start by talking a little bit about factors affecting distribution. So distribution is essentially how the drug moves across the body in the different compartments of the body. So if we remember, there's the bloodstream, then there's interstitial fluid, and then there's intracellular fluid. How well does the drug move between these compartments? So the first thing to know is that the first thing that influences distribution is just the way a drug can move across a membrane. So if a drug can move across a membrane well, it's going to move into intercellular or interstitial fluid quite easily. But if it isn't able to move across a membrane, it's more likely to stay in the plasma or in the bloodstream. So then you also think about the things that can change distribution are also like the delivery to certain tissues. So certain areas of the body will have more blood flow than other areas of the body, and therefore drugs will move more towards those areas of the body that have higher perfusion. Then also we have the consideration of, does the drug, when it gets to the site, actually stay at the site? So if it goes to the site, say the tissue, is it in an active state? Also, does it stay at the tissue and actually have its desired effect? So this leads us on to the concept of volume of distribution. So the volume of distribution is the amount of a drug that appears to have moved out of the bloodstream and into the tissues. So the keyword here really is appears, because volume of distribution is something that's not necessarily a practical concept, but it's more something that gives you an idea of how well a volume of distribution or how well a drug actually moves into the target tissues. So the way the volume of distribution is calculated is it's the dose that is given to a person divided by the concentration of drug in the blood. So what that essentially means is if you know that you injected, say, 50 grams of a drug into a person, and then you check the concentration of the drug in the blood, and let's just say for the sake of an example, it's 25, then you can assume that maybe 25 grams of the drug has moved into the tissues or the interstitial fluid. So that's sort of the way volume of distribution is used. And it's essentially a measure of how well a drug moves in between tissues. So the reason a volume of distribution is not particularly accurate is that for the factors that we mentioned before, the fact that certain areas of the body have less perfusion than other areas, and also because certain compartments will have less or more of the drug than other compartments. And then also there's the factor of excretion and how fast the body excretes the drug. But the good thing about volume of distribution is that the volume of distribution for most drugs is known, and it's been calculated by an estimate. So what that means is when you have a look at this table on the right here, you see that, for example, warfarin has a very low volume of distribution, for example, which means that it does not perfuse, it does not spread into the tissues very much. Whereas chloroquine does spread and enter into the tissues a lot, which means that it has a high volume of distribution. So now I've sort of touched on this already, but how is the volume of distribution actually used? So the way it's used is you can calculate the dose required, or the loading dose, for a desired plasma concentration of a drug that you want. So since you know the volume of distribution already for all drugs, And you know that the volume of distribution is the dose that you give to the patient divided by the concentration of the drug in the patient's bloodstream. Then you can rearrange this equation. So you take dose to the left, or you take plasma concentration to the left, and then you just have dose equals the volume of distribution multiplied by the plasma concentration that you want to achieve. So as a result, what you can get is you can get an idea of the loading dose that you want to achieve to get a certain plasma concentration for a drug. The other thing is that you can also estimate the rate of elimination of a drug, which means that if you have an increased volume of distribution, that means you'll have less in the plasma, which means that you'll have decreased elimination of the drug and an increased half-life of the drug. And we'll talk a little bit about what half-life means in a bit. So now we get on to the second stage of this, which is about metabolism pathways. So this diagram is from our lecture last year, and it summarizes it pretty well. You have a drug, and either it can be excreted straight away through your kidneys as the active drug itself, but a lot of active drugs aren't actually water soluble, so they cannot be excreted by your kidneys, which means that they have to undergo metabolic degradation. So metabolic degradation usually occurs in the liver, and as a result, then it gets converted into a form that either can be excreted by the kidneys, or it can be again excreted by the hepatobiliary system. So there are a few factors that affect metabolism. And so, as I've touched on already, renal excretion, so excretion from your kidneys, requires the drug to dissolve in water or be hydrophilic. So as a result, most metabolism occurs in the liver, and a lot of this is driven by enzymes. So what happens here is that there are, in general, two stages of enzymatic metabolism. So the first stage is catabolism into hydrophilic products. So this is usually done by a series of enzymes, and a very important series of enzymes here is the cytochrome P450 enzymes. And this is a family of enzymes that are important in many drug metabolism reactions. So these are also called CYP450 enzymes, and they can be influenced by genetics, herbs, and other drugs. And a notable example here is St. John's wort, which increases the function of these CYP enzymes, and therefore means that a lot of drugs might be metabolized faster if the patient is also taking St. John's wort. The phase 2 of enzyme metabolism is anabolic, which means adding up. And what happens here is there might be an addition of a polar compound or a compound onto the drug itself so that it becomes more hydrophilic, and therefore it can be excreted more easily by the kidneys. Note also that excretion can occur through the lungs, the gut, sweat, saliva, mucus, also tears, and milk. And importantly, if a drug is excreted through milk and there's a mother who's breastfeeding, it can have negative effects on the baby. So now that we've covered metabolism and also volume of distribution, we get to clearance and half-life. So just like volume of distribution, the clearance, which is the rate at which a drug is cleared from the plasma per any unit of time, is known for all drugs. So as a result, from the clearance of a drug, you can calculate the rate of elimination, which is the clearance multiplied by the plasma concentration. The other important concept here is that of half-life, which is that the half-life of a drug is the time taken for the drug plasma to fall by 50%. And, the half-life is dependent on the clearance rate and the volume of distribution. And the reason that's the case is because the volume of distribution essentially tells you how much of the drug is actually in the bloodstream. And then the clearance rate tells you how much of this drug in the bloodstream is taken out of the bloodstream and excreted per unit of time. So then you get that the T half-life is equal to 0.693, which is a constant, multiplied by the volume of distribution over the clearance rate. And ultimately, the half-life determines the duration of action and the time required for drugs to be eliminated. So this leads us on nicely to elimination kinetics. And essentially, there are two types of elimination kinetics, and they're very simple: zero order and first order. So what zero order tells you is that regardless of the dose of a drug, the rate at which the drug is eliminated will be constant. So what this means is that, for example, there might be saturated enzymes, and this happens a lot with alcohol, which we talked about last semester, and the drug can only be eliminated at a certain rate. So as a result, the half-life is not a constant, and the dose that you give actually changes the half-life. On the other hand, first order elimination kinetics is where the dose actually does change the rate at which elimination occurs. So if there's a higher dose, the elimination will also increase. If there's a lower dose, the elimination will decrease. This means is that there are unsaturated enzymes. So as the amount of the drug in the bloodstream or in the system increases, there's also an increased number of enzymes to match that. So as a result, what you get here is that the T half-life is actually constant for drugs with first order elimination. And the application of this is in maintaining therapeutic levels. So you might understand from your lecture last semester that drugs usually need to stay within a therapeutic window, which is below the rate at which drugs are toxic and also above where they're useless. So the way you can get these steady state concentrations, which means that the drug is staying within the therapeutic window and the level or amount of the drug in the concentration isn't too high or too low. And what you have as a result is that this can be achieved either through constant infusion, which is intravenous infusion that gradually declines. So at the start, you give a large amount so that the concentration of the drug increases slowly, and then you slow it down over time so that it doesn't increase as slowly as the enzymes get more and more saturated. However, this isn't necessarily practical because it's unlikely that most patients will be able to have access to IV at all times. So what happens more often in practice is repeat dosing. And that's what you see here in the diagram on the right, on the bottom. So what happens in this case is that you're given multiple doses to stay within the therapeutic range. So each time the concentration in the plasma increases slightly, but then it decreases, but then you give another dose so that it increases again before it can decrease all the way to zero. However, what you can see is that giving a loading dose, which is the example on the left in the diagram, allows you to reach the therapeutic range much faster. And then as a result, you get the maintenance dose, which can allow you to stay within the therapeutic range. But this allows you to reach steady state much faster than you would otherwise. And a little thing here is that the time taken to reach steady state is usually 4 to 5 half-lives. So just to finish off here with pharmacokinetics, there are a few important equations that we've talked about. So volume of distribution, which is the dose that's been given to a patient divided by the concentration of the drug in plasma. There's the rate of elimination, which is clearance multiplied by the concentration of drug in plasma. There's the T half-life, which is equal to 0.693. That's the volume of distribution on clearance. And then there's the maintenance dose rate, which is the clearance multiplied by the target drug plasma. The loading dose, which is the volume of distribution multiplied by the target drug plasma. And the time to reach steady state, this is 4 to 5 half-lives. And this is sort of summarized here on the right in the pharmacokinetic triangle. I personally find this diagram sort of confusing, but if you can make sense of it, that's also a nice way to understand all these equations. And that's it for me.
Beautiful. Thanks, Emil. I'm just going to take us through bacterial pathogenesis lectures 1 and 2 quickly. So to start off with, we'll just begin with a quick revision of the cycle of infectious disease. If you can go to the next slide. Thanks, Emil. Okay. Perfect. So you learned about this last semester. I'll just go through it again this semester quickly for you. So you've pretty much got your first step is transmission or contact. So that's how you get the pathogen. Then the pathogen enters into your body and colonizes. It manages to avoid or overcome your host defenses, and that's what I'll be talking about today. Growth and spread, and then damage to the host. So I'm going to be talking a little bit about these steps today. But first of all, I'll just start by reminding you about what our defenses are. So our defenses that we do have, next slide. So we've got our skin, we've got our intact skin, which provides a barrier. We've got our stomach, our low pH and enzymes of the stomach can also kill pathogens. The mucous membranes of our body are a protective layer which prevents adhesion because they're very hard for the bacteria and pathogens to attach to. We've got mechanical mechanisms of defense, so like coughing, vomiting, which ejects and rids our pathogens, and we've got secretions as well, which have flushing actions and enzymes. Then we do have our innate immunity, so we've got our leukocytes and macrophages, which have bactericidal effects and also are microbe toxic. So that means that they're able to kill the pathogens. But the defenses that just stay in our body is more like our skin, our mechanical defenses, and things like that. Perfect. And our normal flora, our body is filled with normal flora. So not all bacteria is actually pathogenic. We have a ratio of 1 to 1.3 bacteria. So we have 1.3 bacteria cells to every normal cell in our body. That equates to over 100 trillion bacteria cells. So when you hear bacteria, you don't automatically have to think the bad guys, because a lot of the bacteria that we do have is actually good for us and it is beneficial. There are a few sterile sites that bacteria shouldn't be in though. So like our blood, our cerebrospinal fluid, our lower respiratory tract, the urine and the bone. And as you progress through this semester and year 2, you'll learn about kind of what happens when bacteria gets into these kind of sterile sites as well. And when the bacteria does become invasive and enters a sterile zone, that is when it becomes a pathogen. So next slide. So a pathogen is pretty much just an organism capable of causing disease. So technically all of our bacteria could be a pathogen, but not all of it does become a pathogen. And pathogenesis is the process by which this organism does cause disease. Virulence, these are just a few definitions. So the virulence is the measure of the ability of an organism to cause disease, and the virulence factors are factors expressed by the pathogen which allows it to cause disease. So a bacteria isn't always a pathogen, but through pathogenesis it does become a pathogen and then can express virulence factors to cause disease in the host. So next slide, I'm going to be talking about the stages of pathogenesis. So we kind of covered this in the first slide with the recap of the stages, but you've got your invasion, you've got your survival, and you've got your evasion, and then you've got damage. So invasion consists of adhesion, degradation, and entry into the cells. Evasion consists of avoidance of the immunity and avoidance of phagocytosis. And then following evasion comes the damage stage, and that's when bacteria releases its toxins and superantigens and can have really quite devastating effects on the host. So we'll start with invasion. So stage 1 is adhesion. So adhesion consists of the colonization of mucous membranes using the host cell receptors as targets for adhesion. So you've got a few different ways in which this can happen. You've got express attachment, which is otherwise known as fimbrial attachment, and that's when the bacteria makes contact indirectly through hair-like structures to the host cell. So an example of this is Neisseria gonorrhea. Then you've got afimbrial attachment, which is direct contact through surface adhesins. So if you imagine the bacteria do have to go directly next to the host cell, whereas with express attachment, the bacteria doesn't necessarily have to be right on the host cell, but it can have the hair-like structures, the fimbriae, which actually allows it to gain access into the host cell without having to come up quite alongside it. So that's why it's express, because the bacteria doesn't have to approach the cell completely. Another method in which the bacteria can adhere is through the glycocalyx, which is otherwise known as a capsule. So the bacteria can form a capsule around it, which helps it to adhere to the host surface and evade the immune system. So this glycocalyx is actually a very sticky polysaccharide, and that connects right to the host cell membrane. So it means that it just makes it so much easier for the bacteria to invade into the host cell. Another way in which bacteria can become integrated into the cell is through coating themselves in the host extracellular matrix. So an example of this, a famous example of this, is Staph aureus. Another thing that this also does though is it helps it to evade immune response later on, and I will touch on this later. But by the bacteria coating themselves in the host extracellular matrix, it helps them both with adherence and it also helps them to evade the immune response, because from the outside it seems that this bacteria is part of the normal flora. And then biofilm is one final method of adhesion. So several hundred bacteria will link together and they'll form like a mat-like structure, which can cause, and it's a mat-like structure adhesions. This big conglomeration of bacteria will then stick onto the host cells, And it just makes it really hard for the immune system to destroy them just because there's such a large number of these bacteria. Okay, next up we have just some examples of adhesion. So this is what it looks like. So the first one is your fimbrial attachment, your express fimbrial attachment, and you can see these hair-like structures approach the host cell. They'll attach to the receptors, and it's just a really easy way for them to adhere to the cell. But then if you see this one, this is the non-express like direct attachment method. And you can see here that the bacterial cell wall has to approach the host cell membrane completely to be able to attach itself and begin its invasion. So next up we have degradation. So this is how the bacteria start to break down host structures and their defense mechanisms. And usually this is through enzymatic activity. So first of all, we've got the extracellular matrix breakdown. So this allows the bacteria to invade the host cell more deeply. So the collagenase breaks down the collagen, and the hyaluronidase directly degrades the ECM. So both of these enzymes work together to degrade the extracellular matrix and really allow it to invade deeply the host cell. One other example of an enzyme which is used, this one's mainly used by Helicobacter pylori, which you'll learn a lot about in second year, but it's an example that they might use in the exams. So this bacteria releases urease and it creates an ammonia cloud, which then damages the lining of the stomach and allows the bacteria to go further into the stomach. So it kind of degrades the mucosal lining. The bacteria can also cause coagulation. So they, using coagulase, they clot the blood around the bacteria, which turns fibrinogen to the fibrin. And this kind of allows the bacteria to hide for a long time, because if you think the bacteria is then encased in a blood clot, and obviously the immune system won't attack its own blood clots. So then later on, once the bacteria is replicated, has invaded the host cells enough, the clot will be dissolved by streptokinase. So this is a pretty clever way in which the bacteria can evade the immune cell response whilst also like degrading the immune system, and then also degrading the immune complement. So it allows itself, the bacteria has an IgA protease which cleaves the secretory IgA and then allows itself to escape from these. You'll learn about this more in the lecture, more in depth, but there's these neutrophil extracellular traps. And it just pretty much, the bacteria is able to escape these traps through the enzyme DNase, which then breaks down the DNA, which is trying to trap the bacteria. All right, next slide. We've got entry. So now that the host has adhered and started to degrade on the cell, it needs to enter into the host cell. So we've got two mechanisms. The zipper mechanism is where adhesins bind to the host cell receptors. The membrane then curls around the cell and pretty much eats it up. So you've got Listeria monocytogenes and Neisseria gonorrhea are two key examples of this. And then the other mechanism is the trigger mechanism. So this is where a molecular syringe injects effector molecules, which triggers the entry of it and places the bacteria into a vacuole. So one comes, you can see a little diagram here, but the zipper mechanism, you can see it kind of opens up the cell and then the cell closes around it, whereas with the trigger mechanism, it injects from the inside and then forces the cell to open up and engulf the bacteria. All right, next slide. So just touching on evasion. So some ways in which the bacteria can evade the immune response is by mimicking through antigen mimicry, and this is where it continuously changes the antigen so the immune response can't bind to it. So bacteria have become smarter and smarter over the years. There are a lot of bacteria that can just continuously change their antigens and change which antigens they're expressing. So the immune response might build a response to one certain antigen, and then it goes to attack the bacteria, but the bacteria is no longer expressing that antigen, so it can't bind and kill all the bacteria. The bacteria can also mimic host polysaccharides. So the host doesn't actually sense invasion if it changes its outer capsule and changes its outer extracellular matrix. And then there's also ways for the bacteria to prevent destruction by the innate immune system by avoiding the phagocytosis. So if you have a look at these diagrams down here, you can see that the bacteria can release cytotoxins, which kills the phagocyte, so it prevents it from coming into the bacteria to begin with. The bacteria can also have the capsule, like I was talking about before, which prevents any interaction with the phagocytes. You've also got bacteria can fuse the phagocyme and the lysosome, which inhibits intravascular killing. And it also if you have a look at all these diagrams, it's got many different ways in which it can avoid phagocytosis, but probably the most common ones are release of cytotoxins and the capsule, which prevents any interactions. So next up. Now we come to damage. So damage is kind of the final step in the bacterial pathogenesis. This is the one that causes the most damage to the host cells. So you've got two different types of toxins. I'll start with that. So you've got endotoxins and exotoxins. Endotoxins are the ones that you kind of hear about causing septic shock in the host, and endotoxicity. So you've got, these are only produced by gram-negative behavior, and they're released upon the death of a cell. So they contain the lipopolysaccharide, and the active component in them is called lipid A. An exotoxic is released by every bacteria. So a range of effects, but it's secreted regularly by bacteria when they die. But endotoxins are the ones you really need to look out for. So damage mechanisms. So bacteria use weaponry to damage the host cells and tissues. One example of this is superantigens. So bacteria can cause excess activation of the immune system. So antigens presented by the bacteria can cause 20 to 30% of all T cells in the body to become activated. So usually when you have a bacterial infection, you have 0.001% activated. But if you've got non-specific antigens, superantigens, that can cause 20 to 30% of all your T cells. So this can cause a massive cytokine storm, which can precipitate toxic shock syndrome and organ failure. And a common example of this is Staph aureus, found on unsterile tampons. And that's one of the, I'm sure there's a lot of horror stories that have been heard about this, but it's actually really dangerous, this super antigen, because usually you would think that T cells are good, but in too large of a measure, they're not good. They can have devastating effects on the body because they just start attacking your own organs. So surface toxins are another way in which bacteria can use weaponry. So they've got surface toxins, for example, phospholipase, which is an enzyme that leads to cell lysis, and it kind of kills the membrane bilayer. You've also got cytolysins, which punch a hole into the cell membrane, which leads to the bacteria being able to move from cell to cell, and it also leads to the cell spilling all of its contents. So these surface toxins on the bacterial surface are then able to go and kill the host cells. So they kind of can lead to cell lysis, they can lead to cell puncturing, they can lead to all sorts of ways, just as much damage as they can inflict on the host cell if possible. All right, next up we have some intracellular methods of damage mechanisms. So one example is your intracellular toxins, which are found on your bacteria surface. So you've got two components in these intracellular toxins. You've got your A component, which is the active component, and that causes the cellular effect desired by bacteria. And you've got your B component, which is for binding. So this pretty much just tricks the host receptor into letting the bacteria into the host cells. So the A and B components work together to kill the host cells, but they're not always needed in the same ratio. And I've just got two examples that you need to know. So diphtheria is a simple AB. So you've got your an A to a B. So the catalytic A component stops the ribosome, and this pretty much causes a buildup of necrotic tissue because the ribosome isn't able to work anymore, and it means that the airways can become obstructed of the person. Then you've got cholera toxin, which is an AB5. So for every A, there's 5 Bs. And this is actually a compound toxin. So it increases the C amp and causes electrolyte release and a disrupted ion balance. So this is pretty bad because when you've got a disrupted ion balance, you lose a lot of water. So then you've got rice water stools because it's coming out in, you'll learn a lot about this in year 2, but it leads to the clinical sign of rice water stools, and this can eventually lead to death. So it's actually really dangerous, a really dangerous disease, and that's just the ratio, just so you know. So there's, you can have simple AB, so AB just 1 to 1, but you can also have the complex and compound toxins, which is AB5. So you can have it in different ratios. All right. And then a final note on damage, you've got neurotoxins. So the protease enzyme produced by bacteria can act on the neurotransmitter and leads to paralysis. So you've botulinum toxin can cause flaccid paralysis through the blockage of acetylcholine release. And then tetanus toxin can cause spastic paralysis through the blockage of an inhibitory neurotransmitter release. So they're just two different ways in which a bacteria can affect your nerves as well. So through the protease enzyme released by these bacteria. And then just a note on septic shock as well. So this is like the end stage of damage. If you've got septic shock, there's been a lot of damage from bacterial invader. So sepsis is when your whole body goes into a systemic inflammation, and this is usually in response to infection. Septic shock is following sepsis. So following this systemic inflation, which is when a cytokine storm kind of induces hypertension, and then it also follows sepsis. So this is really bad. Endotoxic shock is different though. So sepsis is not the same as endotoxic shock. Gram-negative bacteria can cause sepsis, but endotoxic shock is also caused by gram-negative bacteria, but they're not the same thing. If you say sepsis, sepsis is just a systemic inflammation in response to infection, but endotoxic shock is specifically in response to gram-negative bacteria. So endotoxic shock is pretty much when the gram-negative bacteria releases endotoxins into the bloodstream like we were covering before, and this can have massive effects like fever, shock, coagulation, weakness, inflammation, organ death, and intestinal hemorrhage. So that's all on bacterial pathogenesis. On to you, Ethan.
Hey guys, a bit of a shorter week from me this week, and I'll be talking about the elbow, wrist, and hand examination, following on from what we've learned about the shoulder examination last week. So it's the same principles really of your musculoskeletal or MSK exam. We always start our exams with general appearance, just looking if the patient's comfortable, any abnormal postures, the patient's body habitus, pain, distress, if they're using any aids like crutches, and any visible deformity that we can see. After our general appearance, we'd get the patient's vital signs, and then we go into a closer look or a closer inspection of the site of presenting complaint. We're looking for the similar things as we did in the shoulder. So deformity, muscle bulk or wasting, swelling, scars, redness, rashes, nodules, or lumps. And it's good to, I guess, have an idea of what all these things are and why we look for them. Obviously, you can correlate a couple of these to actual musculoskeletal injuries like fractures and pulled hamstrings and pulled tendons as well. But it's worthwhile thinking about the relevance of everything we're looking for too. Because when you're doing a practice OSCE and someone's watching you do an examination, if you do forget things, it can always be useful to think, well, what would I actually like to know if someone actually was presenting with this? So after we've done our general appearance, vital signs, and having a closer inspection of the site, then we actually get into an actual practical component of the exam. So we feel for our surface anatomy landmarks, we feel for temperature using the back of our hand, we feel for the muscle bulk, tenderness, and also any swelling. When we do different examinations, it's always good practice to have the joint above and below exposed. So when we were examining the shoulder, we had the elbow and the neck exposed, and this principle will hold true for the remainder of the upper limb. So if we're looking at the elbow, we'll generally have the patient's shirt off because we need the shoulder exposed. And if we're at the wrist, rolling up the sleeves is sufficient because we need the elbow and then the finger joints exposed. And so we will need to remove any rings for that as well. Okay, after we, I guess, do all the looking, what are the surface anatomy landmarks we need to find? Well, this is just a bit of revision for the upper limb anatomy that we've done. So at the elbow, there's really 3 bony bumps we need to look for. And if you feel your own elbows, the main bony bump, which is the posterior ulna, is the olecranon. And then either side of the olecranon, you can feel 2 bony bumps, and they are your medial and lateral epicondyles. They're important parts of the humerus. And if you can remember that the medial epicondyle is the site of origin for many of your forearm flexors, and the lateral epicondyle is the site of origin for many of your forearm extensors. And that's going to be relevant when we get into some of the special tests. There's a little gap that you can feel between your olecranon and medial epicondyle called the ulnar groove. And you may have noticed there's a really funny feeling when you get hit in this gap because your ulnar nerve runs through there. And it's about a finger width wide, so it's quite easy to palpate if you get the right region. When we get to the wrist, it's worthwhile thinking about the 2 bones in your forearm, so the radius and the ulnar. The radius is quite a lot bigger at the wrist, it's the opposite at the elbow, and the radius is located on the side of your thumb or the lateral side, and the ulnar on the side of your pinky. Distally, the radius and ulnar have what we call styloid processes, and those can be seen on guess, the lateral and medial sides respectively. So the edge of each bone sticks out a bit, wraps around the carpal bones, and we call the edge of each bone the styloid process. The listus tubercle is a bony bump on the radius, and you can feel it sort of if you track your index finger down into your wrist and line it up with the styloid processes, which you can feel either side of your wrist. So if you feel for two bony bumps there, you can get the styloid processes. And then on the back of your hand, if you run down the index finger, you'll feel a bony bump around the same level, and that's listus tubercle. It can be helpful to pull up a diagram of that perhaps before you feel for it. Feeling for each carpal bone requires a specific technique, so your tutors will go through that. But it can be quite difficult, but what's going to help is if you actually know your carpal bones before that tute. So, pull up a diagram from Google Images or Teach Me Anatomy and revise them, because there are ways to feel for each specific carpal bone. And the anatomical snuff box is the last thing that we're going to have a look at. If you can remember, that's a triangular area made by some of the extensors and abductor tendons in your thumb. At the fingers, we're going to look at the metacarpophalangeal and interphalangeal joints, and that includes both the distal and the proximal joints. All right, after we've done our feeling, we can actually get into the movements. And it can be useful to think what type of joints we're looking at each section to actually look for the movements that we need to examine. So if you remember, the shoulder joint is a ball and socket joint. So that can permit a whole range of movements, including flexion, extension, abduction, adduction, and internal and external rotation. Whereas the elbow is just a hinge joint. So that can only do flexion and extension. Flexion can occur to 150 degrees and extension is to 0 degrees. And pronation and supination, even though I've got them under the elbow bracket and you'd perform them in an elbow examination, they actually occur at the radio-ulnar joints, and they can occur each to 90 degrees. Wrist flexion and extension are to 75 degrees, and ulnar and radial deviation are to 20 degrees. So the wrist isn't quite a hinge joint because we can actually perform abduction and adduction or radial and ulnar deviation. At the fingers, we'll perform flexion and extension of the MCP, PIP, and DIP joints, abduction and adduction, and opposition and reposition. Remember, opposition is the movement that brings your thumb to each finger so that they can touch. Knowing the exact number of degrees for each movement, I'd say is quite overkill. I think it is a possibility that you get asked on it, but try and just make sure, I guess, the numbers make rough sense rather than committing each particular number to memory. So that's move and measure, and now we head into special tests. So I guess with your MSK exams, you can remember the general structure of look, feel, move, measure, special tests. You'll be in a pretty good position. I mentioned the epicondyles before, and that's because two of our special tests are going to focus on the muscles that originate from each epicondyle. So at the elbow, we can test for lateral epicondylitis, and that test just involves bringing the patient's hand out, cocking their wrist back, performing extension, and then adding some pressure there. So you sort of forcefully perform extension, and any inflamed forearm extensors will produce pain there. And medial epicondylitis is quite similar. It's the same thing, bringing the elbow out, but now we're flexing the wrist instead of extending it. And that'll test the forearm flexors as they all originate from the medial epicondyle. At the wrist, we have two tests for carpal tunnel syndrome. If you can remember, the median nerve enters the wrist by a narrow tunnel called the carpal tunnel, and inflamed tendons in that tunnel can compress space and lead to damage to the medial nerve. The two tests include Phelan sign, which is where you have your wrist back to back like this, and you've got to hold that for 60 seconds, and Teele sign, where you tap on the carpal tunnel for 30 seconds. You can remember Teele sign and tapping because they both start with T. At the hand, we have 4 function tests. You might use the mnemonic GP-OK to remember them, but we're testing grip strength, the ability to grip a key, a practical test, which can be something like writing, and opposition strength, which is where your patient performs opposition and you resist that movement. So on the next slide, I've got pictures of each test. The These are from PS Platypus last year. Again, it'll be the best way to practice them will be in your tutes with your tutor, but try and correlate each of these pictures to the respective test and think what movements are being assessed or what pathology is being assessed for with each test. So that's all from me, and hopefully you've found the session beneficial today. And as always, let us know if you have any questions. Thanks very much for coming, guys.